Good evening, everyone. We're so excited that you have chosen to spend your evening with us. Welcome. Also, welcome if you are watching this after on YouTube or wherever you found us. We have an exciting conversation, hopefully, an evening packed with learning. A couple things while we give people time to join, and then I'll introduce our amazing group of panelists this evening. We have our social media channels where you can find information on events coming up. You can hear directly from our experts. We're at Columbia Pediatrics. So find us there. We also have an exciting virtual conference coming up December 6th through the 7th. It is the 12th annual Pediatric Specialty Updates for the General Practitioner. And at least a couple of our panelists here tonight will be speaking at this conference. After you register, which the price is super competitive, after you register, the talks and sessions are available for 3 months after. So definitely, even if you have a holiday packed weekend, definitely consider registering. We also recently opened at New York Presbyterian the One. Our Columbia experts are going up there, our subspecialists. So just a reminder, if you are in the area as a provider, you can refer. This is the number, and we will be sending it out after the webinar. And if you are a caregiver, family member watching this evening, and you are closer to White Plains, Westchester, that is also an option for you now. So very exciting things happening. And without further ado, let me just introduce our experts. I forgot to introduce myself. I'm Edith Sanchez. I am a primary care pediatrician here at Columbia. I also lead our external affairs team. We have with us Dr. Gabriella Paskin, who is a developmental pediatrician this evening. We also have Dr. Evelyn Berger, who is a primary care pediatrician, and Dr. Jennifer Bain, who is a neurologist. I just couldn't think of a better group of people to have this conversation with. So let's get started. Let me just very briefly stop sharing. And as a reminder, as we talk, you can send us your questions. So let's start perhaps by introducing yourselves and briefly your role and your experience in working with children with autism. And because you're first on my screen, Evelyn, we can go first with you.
Great. Good evening. I'm Evelyn Berger. I'm a general pediatrician, so I see patients ages 0 to 21 in our outpatient clinics where our rates of positive MCHAD and autism concerns are very high here in Northern Manhattan. I also help lead some community-based mental health prevention programs, really focusing on early identification, and also lead our mental health training program for our residents here at Columbia.
Amazing. Gabby, let's go to you next.
Hi, I'm Gabby Paskin. I am one of the developmental behavioral pediatricians here at Columbia. I diagnose, evaluate, and follow children with autism or any neurodevelopmental differences here throughout the early lifespan. And so see many children who have autism spectrum disorder.
Yeah, we send many children to you and Jen as well. So Jen, let's go to you next.
Hi, I'm Jennifer Bain. I am a child neurologist, so I'm trained in both general pediatrics and neurology across the lifespan. I see patients down at the Columbia Main Medical Campus Center. I also go up to the New York Presbyterian Center for Autism and Developing Brain up in White Plains, not too far from the One. And that is actually one of the multidisciplinary hubs for autism care across our campus. So I do see patients for neurology consultations up there. My practice is in neurodevelopment, including autism. I do a lot of genetic disorders associated with autism, as well as other related disorders. I have a very neurodiversity affirming practice. I'm also the training director for the child neurology residents.
And hopefully everyone can see why I asked you all to come this evening. Just such amazing expertise. Let's start, Gabi, perhaps, with defining. Because I think when families hear autism spectrum disorder, they may picture very different things. So how do you define autism today, and what do you wish more people understood about the definition of autism itself?
So I think you're right that the definition and diagnosis can be confusing to many families. So to remember, the autism spectrum is very wide. And so what we're doing is describing kids at all different levels based on a set of criteria that are written up in a manual called the DSM-5. So we are looking for differences in social communication skills, as well as the presence of some what we call restricted and repetitive behaviors or patterns of interest. So we're looking to see how kids use their nonverbal skills, how kids are using engaging in kind of a back and forth interaction with others, how they engage with peers, how they play with toys, as well as the presence of any of these additional behaviors. So we might be looking for kids who repeat language or have some repetitive behaviors like hand flapping or toe walking, as well as kids who might have some rigid behaviors, difficulty with changes in their routine or transitions between activities, kids who might have sensory differences, either hypo or hyper sensory differences, so not liking the way things touch or actually really liking certain sensory objects or kind of liking water or loud noises or different things like that. And the last is sometimes we see kids have very focused interests on certain topics, like anything, planets, the human body, just a topic, a great interest in a topic that is beyond what we would expect for their developmental level. So remember, we are looking for those features in all different kinds of kids. And so this looks different in every child. And that is why it can be so confusing.
Yeah, no, definitely. And I think one thing, you say a lot, and I've heard you say a lot, is once you've met a child with autism, you've met one child with autism, right? Like they're really just so different. Now, Jen, to go to you and Gabby starting to get to this, what are some key features, red flags, right? We've talked about what we're looking for, how different it can be for a parent who is, very early, right? Very young child. What are the things that you would say these are key features, red flags, not to be ignored, needs an evaluation for autism?
Well, first of all, I have to pitch all of our general pediatricians and primary care providers because they're literally the ones that are seeing kids as they develop over time. And just that building that relationship and that trust with your primary care provider so that they can see how your children are developing is really important. Things for us that we would ask parents to take a look at are number one, social and communication difficulties. Often people say avoiding eye contact, not responding to name, difficulty sharing their environment, sharing their interests, showing gestures, things like I'm doing with my body language. A 6-month-old baby goes up to somebody and goes, and that's great because it shows us they're using language, they're using facial expressions, they're using body gestures. Gestures are really important, and knowing that a child really is wanting somebody to engage with them is key here. So when those type of social cues are not happening naturally and having to teach a child, that's concerning. Language is definitely something we think of stereotypically that somebody has delayed language, so delayed speech. So certainly not babbling by 12 months, maybe not putting phrases together, losing language. Typically, it's not uncommon for a fair number of patients with autism to have language regression. Typically, it does happen around that 12 to 18-month time period. Repeating words, phrases like echoing, and then things like Dr. Paskin mentioned, like hand flapping, repetitive movements, rocking, spinning, very specific interests, getting upset by really small things and maybe having some sensory reactions. I will put in a plug that we know that autism is across all races, all ethnicities, all languages. And so we do need to be aware that patients might be going under the radar if our providers aren't matched up with necessarily the language of the family and recognizing the social cues that might be seen in one race or ethnicity or language than another. And importantly, females often do have some different red flags. For example, they might have good eye contact, but still have autism. And so these are certainly not one and all. For me as a neurologist, we actually see a lot of global developmental delay with motor problems. So we do know that a lot of motor delays also are a red flag for autism.
Yeah. And it's, it's so interesting because I've had a couple of families after conversations like this, podcast, consuming information, right, who were just so early in recognizing those signs. And it's so rewarding to see, right, when a family comes to you and says, I'm worried about XYZ, right? Let's get going with some of these evaluations and how helpful that can be. So hopefully, again, something people are consuming and looking up in reliable places. Gabby, there's been a lot of discussion about the rise in autism rates. As you know, I don't have to tell you. What do we know about why that is? Is it more cases, truly? Is it better recognition? Is it changes in diagnostic criteria? Is it all of the above? What's happening?
So overall, I think most of the experts would say we don't really think it's an actual rise in number of cases, but kind of a change in how we're talking about autism. So one thing is like so many people know about autism now that used to not know about autism. We're screening regularly at the general pediatrician's office, right? We do MChats at set. So we're identifying kids earlier, and families are coming to see us and saying like, I saw a TikTok video, my child, like of a child doing this. I'm worried my child has autism. Like that happens to me all the time now. And so like it is much more common for parents to raise concerns about developmental things that they're seeing for their child with concern for autism. We know that as the criteria have broadened over the years, it's definitely the umbrella of what is included in the autism spectrum is much wider or more inclusive. And so it's having a lot more kids fit under that umbrella. Most of the kids who are new to the autism spectrum umbrella are often on the kind of what we would call the quote unquote higher functioning end, which is that as the criteria got broader, it allowed children with more subtle symptoms to be included, to get, again, to give them a diagnosis, give them access to services and things like that. So I think it has more to do with kind of how we're talking about autism, and less to an actual change in prevalence or like just increasing number of kids.
Yeah, which is so important to to keep saying, because there is a lot of misinformation. Again, I don't have to tell this group. Jen, tell us a little bit about how autism is diagnosed and the benefits of, again, these conversations and the early identification and the screenings that we do in our offices and all these conversations that we're having.
Sure. So autism is a clinical diagnosis. There's no blood test. There's no imaging test. There's no EEG brainwave test. There are some really wonderful technologies out there that are being considered, such as eye tracking and things that pediatricians and other providers could use in the office as a tool. But it is a clinical diagnosis. So again, you have to see your clinician. A patient has to meet a certain clinical diagnostic criteria. There's a book called the DSM-5, and we all utilize this. And there's specific criteria to say this person has deficits or needs support in areas of social communication and interaction, in addition to 2 out of the 4, restricted interest, repetitive interest, rigid interest, or sensory problems. And they have to be present from a young age, and they have to cause problem or challenges. So it is a clinical diagnosis. Where do you go for that clinical diagnosis does vary depending on where you are, what resources are available. At NYP in Columbia, we are constantly figuring out where can we get our patients the care that they need. It could be the psychologist, a neuropsychologist, developmental pediatrician, pediatric neurologist, psychologists, and many pediatricians and primary care providers can accurately make the diagnosis.
Yeah. And so that leads to my next question perfectly. Evelyn, I think, we're getting so much better as primary care clinicians in diagnosing, right? And spotting, diagnosing autism. But I wonder if you can share a little bit, what are the biggest barriers that families still face in terms of getting a diagnosis and getting started with receiving some of the services and therapies that help, right? Which we'll talk more about.
Yes. As we've been talking about the DSM, have always said, we can use the DSM, we can, as pediatricians, look for those clinical criteria and make the diagnoses. The issue with autism is that it's, as we've been saying, different for every kid. It's sometimes subtle, often subtle. And there's this thing called diagnostic overshadowing, where pediatricians sometimes will attribute the symptoms, especially early on, to something else. ADHD, hyperactivity, anxiety. If this happens too, there's bias. And so in certain populations, we're sort of thinking it's something else and I'm not quite sure. And so for all of those reasons, we do rely on the gold standard tests, which are limited. And so one big barrier is just locating people who are specially trained to do these tests. The two that we use most often are the ADOS, which is the Autism Diagnostic Observations Scale or tool. And then the CARS is another one. There are a couple of others, but there are long wait lists, not a lot of folks who are formally trained to do these tests. And as pediatricians, we don't want to make a mistake. We want to really get all of the information, both with the DSM criteria, but also with observations and other things, to put the information together and be sure that it is autism. And that's why there's delays. Another thing is just stigma too, and fear. I mean, this is something that continues, despite the fact that autism rates are rising and we're all more aware. There's still a lot of stigma on both sides, in patients and parents and adults and clinicians. And so I think that contributes to the delay in accepting a diagnosis.
Yeah, no, definitely. And we've all, I think, seen it happen, right, in real time. Now, there is a question that came in, and I think it gets at a larger question, so very timely and appropriate. Thank you for this question. The question is this: I have heard that diabetes and obesity during pregnancy can increase the risk of autism. Could this be a rising cause? Gabby, Jen, Evelyn, I open it to you. Whoever wants to chime in. But I think we're getting at the cost, right? And I think it's an important question because a lot of our families have that question, right? What costs this?
I would say there's a variety of things that feel confident that can cause or increase your risk. So we usually say risk factors for autism. Maternal issues such as diabetes, obesity, poor health habits. We know that mothers who have infections and inflammation and fevers are at risk for passing along some neurodevelopmental diagnoses to their children. And that's something we can talk about later. Like, treating fevers during pregnancy is really important, and we think that Tylenol is the safest way to do that. We do know that there's certain infections during pregnancy that can also put a child at risk. For example, rubella. This is something we don't see nowadays, but babies are immunized against rubella with the MMR vaccine. And congenital rubella, which just causes a common cold in mom, actually increases risk for autism. There are some medications we know that moms can take to increase risk. Seizure medications are probably the ones that we know mostly. So if you have epilepsy and are pregnant, talking with your provider about the safest option is important. And then certainly things like prematurity, small birth weight, and we're keeping babies alive so young that we weren't before. Those are definitely known risk factors for an autism diagnosis.
Yeah.
But I think, just to add to that, to remember that all of those are absolutely risk factors, but the most prominent cause, right, is still thought to be genetic. And we do recommend genetic testing for all children who have a diagnosis of autism. Jen's smiling because she does that a lot. But that it is still thought to be kind of one of the biggest contributors, and then kind of changed by these other risk factors, or kind of the environment, which are these risk factors.
Yeah, you can have more than one, right? So we know that I didn't pitch this, but I do a lot of research in genetics and genetic disorders. Probably 1 out of 3, 1 out of 4 people with an autism diagnosis also have a genetic diagnosis. They can have both. And that genetic disorder could put them at risk for being born premature, being at risk for having brain injury.
Yeah. And it's so interesting because we do, again, I practice per your recommendations, referring and really, sending our families to genetics. But so often there really isn't a diagnosis, like a true identified, like, this is the gene, right? And so it's an interesting conversation to have with families. And at the same time, because when you're here long enough, you care for several siblings at the same time, right? That it is clearly. And happening in front of your eyes to more than one sibling, right? So it's like clearly a genetic predisposition, and yet for some families it's hard to find the gene, and those are tricky conversations to have sometimes with families. Evelyn, I don't know if you want to say anything else about that.
No, I mean, I think it's helpful to have those conversations about that there may not be the one, common cause that we can find now, but we should be open to doing the testing, maybe repeating the testing down the line, and just gathering all of the information we can, though it's not perfect information, so that ultimately we may have an answer, we may not have an answer. But it does help for planning. It helps for planning for future pregnancies and, thinking through how to maintain, the best health we can throughout the pregnancy and just being supportive. The more information, I think, the better in terms of feeling like you're doing the best you can to investigate and inform ourselves.
And I think there's a lot of different providers that you can talk to genetics about. Your pediatricians, there's clinical geneticists where that's their job all the time. Certain neurologists, developmental pediatricians talk about genes. It's not only about knowing for family planning. We know that having one sibling with autism increases your likelihood of having another child with autism. So it's really important. And then having twins, we're at a much higher rate. So we know that there's a significant genetic risk. It's not just one gene, it's hundreds of genes that affect brain development. And we're moving more into the world of not only just doing it just because to know about it, because it's interesting, but really thinking about actionability. And hopefully we'll talk about some up and coming treatments and things that are on the horizon for treatments.
Let's talk about therapies and treatments. And I love the way that you just framed that, right? It's not just one gene, it's hundreds of genes. And Evelyn, I think something else that you just mentioned that's really important is perhaps repeating tests down the line, right? Because additional genes are identified as time goes on. That is a hope, right? Like we want scientific innovation. So anyway, really, really interesting points you all are making. So let's talk about therapies and treatment. So Gabby, let's go to you. Once a diagnosis is made, right, what are the key evidence-based therapies and interventions that actually help and make a difference?
So remember, autism is a clinical diagnosis, and there is currently no medicine to treat the core symptoms of autism. That is like the DSM-5 criteria for autism, right? So sometimes we use medicines to treat things that are comorbid or commonly occur with autism, but there's no medicine at this time to treat kind of like social communication differences and these restricted and repetitive behaviors. So the therapy is the medicine, right? So being in school, getting early intervention, getting your services is the most important thing that we know kids need to help them make progress. So the most common therapies we talk about locally are starting an early intervention. With a diagnosis of autism, kids can have access to ABA, which is the therapy that works on behavior and social communication skills, speech therapy, potentially occupational therapy, feeding therapy, physical therapy, kind of whatever kids might need. And as they get older, those therapies, in addition to potentially like attending a school program based on kind of their cognitive skills, will really determine their ability to participate in class, like determine what type of school program that might look like. But getting services and being in school is the most important thing for kids.
Yeah. And we'll talk more about how to access that and difficulties. But Jen, I'm curious if there are any emerging new therapies that you are excited about.
That there's constantly clinical trials. The purpose of a clinical trial is something that's not yet approved to be safe or effective. But the goal is that clinical trials are constantly happening for gaps in our care. So there's lots of clinical trials out there. For those who are interested, we can put a great website is called clinicaltrials.gov. These are safe, reputable clinical trials that have appropriate oversight. And if you actually just put a diagnosis in there like autism, you can find different clinical trials. These might be behavioral interventions, teaching interventions that Gabby talked about. There's also certain medications that continue to kind of be investigated. We have many clinical trials here at Columbia, New York Presbyterian that we participate in, and there's a lot of wonderful, reputable institutions that are doing these trials. Things that I'm really excited about are the genetics. Actually, now that we know that there is a large group of people who have genetic disorders that are causative or contributing to someone's autism diagnosis, we're starting to kind of go from the ground up and saying, well, we weren't able to kind of impact these symptoms with a certain medication. We can treat, as we were talking about earlier, other diagnoses like anxiety and attention and aggression. But maybe if we go in at the root cause of the problem, and I'm not talking just gene therapy, fixing the gene or giving back the gene, but really thinking about the mechanisms really down below and how genetic disorders lead to eventually these changes in behavior. And so there's some really, really interesting and exciting treatments out there. For example, Angelman syndrome is a genetic disorder that looks and overlaps a lot with autism. And there's some really awesome clinical trials coming through the pipeline and really close to treatment or regulated FDA approved treatments. And they're doing that with a lot of other rare diseases, a lot of other genetic causes. So I'm really eager to see how that plays out over the next decade. I think it's going to be exciting and hopefully much more impactful for the autism groups.
Yeah, no, absolutely. Do you, actually, let's go to a question that just came in. And I know, Gabby, that you have an opinion about this because I've asked you this question before. What is your opinion about dietary modifications and use of supplements?
So anyone can feel free to pipe in if they have a differing opinion. What I would normally say to a family that I see is that there's no strong evidence that any specific diet is needed for a child with autism unless they have a specific issue that would cause them to need a specific diet. Like, so if you also have celiac disease, then we need to deal with that. But just having autism is not, there's no evidence that we need to be on a specific diet. Anecdotally, I absolutely have families who have trialed a variety of different diets, gluten-free diet, casein-free diet, like you name it, we've tried it. And I have some families who will anecdotally report that it makes a difference for them. And we really, so as long as they can do it in a safe and healthy way, I'm not saying that's not okay. Like I will say, I don't know if there's evidence for this, but if they really want to try and it feels appropriate for them and their family, I think that that's okay to try. Sometimes we just kind of try to talk about ways that we can do it in the most evidence-based way possible. So like if you're going to try it, maybe at some point there's an opportunity for us also to trial off to see if we really see a difference, because we know that dietary changes can actually like be impacting for the whole family. So it might be hard, but also just like it means that kids can't eat certain things at birthday parties, difficult at school functions. And so we just want to make sure people are doing it because it's helping, not and so like really seeing that difference. So sometimes I'll recommend that, but I definitely have families who are doing it. But if overall, I would not specifically recommend anything. And the most important thing is that kids have the most balanced diet possible. So what comes up a lot is that many children on the autism spectrum have very restricted diets and have very limited things that they eat. And so for those kids, often having a specific diet is very difficult because they only eat certain things. So we would maybe talk about that not being safe for those kids because they may not eat. They're not as flexible in what they eat. So we can't just like remove certain of their safe foods. But also getting them to take a vitamin or a supplement or taking a new type of diet might not be feasible for those families as well. And so it's just a conversation that you need to have with them. Similarly, there's no evidence-based supplements that any child needs to be on. Again, we want kids to have what we would perceive as a well-balanced diet. We know that not all children with autism do have well-balanced diets because they might be restricted in their eating. And so that's a different story. And like, would they benefit from some supplementation to make sure that they are eating, all the vitamins and nutrients that we think would be appropriate for a growing child? But nothing like just because you have autism, you have to be taking.
Yeah.
No, I can comment too, is that, I think we definitely know that vitamin deficiencies happen in kids with autism because they're so restricted too. So I definitely have seen patients, vitamin D deficiency, which is common in a lot of people, certainly is something common. And we actually see even vitamin deficiencies such as vitamin C causing scurvy. We've seen that in the hospital before because somebody says, my child doesn't eat any fruits at all, no vegetables at all. So multivitamins are really important. Really just working with your doctors about like how do you get a balanced diet as best as you can. Don't restrict if you can't, and really try to eat as healthy as possible, as natural as possible. If I eat McDonald's every day for a week, my body is not going to feel really well. My behavior is not going to feel really well. And so, just general basic ABCs of like health.
Yeah. No, definitely. And I think, Evelyn, from the primary care perspective, I think what Gabby was touching on, right, like kids are picky, like they have very restrictive preferences. And then on top of that, you add this restriction is often something that is hard for us to manage as primary care clinicians, right?
Agree 100%. So I caution against really forcing it or really, I know parents want to do the best that they can to get, whatever treatment may help their child, but it may be counterproductive for all the reasons we said, because they'll become more restrictive if we're forcing a special diet or vitamin, on them.
Yeah. No, definitely. We just had another question come in, and please do send us your questions. If we don't address them right now, we'll try to address them at the end, but please keep sending them in the Q&A. And it was the exact question that I was going to ask you all next. Gabby, I have to ask you about leucovorin. As you know, the Health and Human Services Secretary, RFK Jr., has promoted leucovorin for the treatment of autism. What does the evidence say about its role?
So we're going to do a two-part, me and Jen will both answer this question together. So there's been a lot of news about the use of Tylenol and leucovorin around autism, and we are getting a lot of questions about this, not just actually for kids with autism, but really just like for any child I see who has any developmental difference. I'm getting a lot of questions on this. So at this time, there have been some very limited studies that have shown maybe some improvement in social communication skills in kids with autism, but these studies are very variable and very difficult for us to draw any kind of conclusions from them. So at this time, there's no professional organization is recommending the use of leucovorin to treat autism, because we don't have enough evidence to know if it is effective. What dose to give, how long to give it, what are our outcome measures. And so we really just don't have enough information to know if it would be appropriate at this time. Jen, would you like to tag in?
Sure. So I will plug, we did a recent Autism Science Foundation podcast on leucovorin, myself, two developmental pediatricians, and a child and adolescent psychiatry. So anyone who wants to hear a whole hour on leucovorin, certainly check that out. But let me just back up to what is leucovorin. So leucovorin is it is a vitamin. It's one of our B vitamins. We always hear about B vitamins being one of the good ones. And it's the kind that is really important for turning over cells. Typically, it had been used in the past for people who were undergoing chemotherapy for cancer, because we were kind of using chemotherapy to kill off cancer cells. And so because we were making new cells, we had to give them that extra B vitamin. Also importantly, leucovorin crosses across to the brain. What's in your blood doesn't always get into your brain. And we have like a little barrier there called the blood-brain barrier. And so leucovorin is able to get across there. And there actually are a couple different forms of folate that does do that as well. And so the question of like, well, where did this whole autism and leucovorin question come up? Many decades ago, there was a specific genetic disorder called cerebral folate deficiency. And this is a real diagnosis. Cerebral meaning brain, folate meaning folinic acid, deficiency meaning you don't have enough folate getting from the blood into the brain. And this is a neurological diagnosis. It's very severe, and we see it in neurology. These individuals do typically have seizures, regression in their motor skills. And often their head growth is not normal. So this is a known disorder that we know is very severe. The vast majority of patients who have autism do not have cerebral folate deficiency, that specific disorder. But what they noticed was that in cerebral folate deficiency, when and in individuals who have that diagnosis, they have autistic features, whether they're diagnosed with autism or not. And when they treated the folate deficiency with leucovorin, these individuals actually had less autistic features. So then this kind of went through some other phases of research. Individuals were interested in saying, okay, well, maybe there are individuals who maybe have like lower normal folate. They don't really have that specific disorder, but maybe they have something similar or something wrong with metabolism. I mentioned all those genetic disorders. Some of them do affect metabolism. And so there is a small group, a research group that has done this and has investigated this. And it started mostly in the earlier 2000s and the late 1990s, where they started actually looking at people and saying, if we gave this vitamin, could that be helpful? There have definitely been pros and cons, excitement over these treatments in patients with autism, but they certainly have not been big studies. Again, you can listen to the podcast for a whole hour. But in general, it's a small group of individuals. It's a different reason why these individuals seem to respond to folate, this folinic acid that gets into the brain. And certainly, while there might be a safety piece to this, yes, we think it's safe, it might not necessarily be effective. There's a term called placebo effect. So if you give somebody a sugar pill, they get better because we subconsciously want them to get better. And we do know that in studies involving patients with autism, the placebo effect can be up to like 50%, meaning half of the time, even if you gave someone a sugar pill, they look like they got better. And there's a variety of reasons why that's the case. But that's beyond this discussion. In general, what we're saying is that there are probably a group of people that would benefit from folinic acid. We don't know who they are. And we need more trials. We need more research. And I'm excited that the government is taking an interest in this, and hopefully we'll have more evidence to tell providers, yes, these are the people that would benefit from it.
Yeah. And I have to tell you, I mean, first of all, it's so helpful to understand sort of where this even came from and how it works in the brain. I have had families message me, Evelyn, I'm sure you have as well, saying, can you test me to see if I have this deficiency or if I would benefit? So just to be extremely clear, right now, there's no test that I can physically send to see if this would be helpful to them. Is that correct?
So Gabby mentioned genetic testing. Everybody with autism should discuss genetic testing with their provider. That would tell you if you have the folate receptor genetic disorder, like that really early one. There is, however, a small group of individuals who have antibodies in the blood that potentially is related to lower folate in the brain. This is still not, it is clinically safe to do the test. It's called the FRAT test, but we're not recommending it for patients. It is not clinically recommended. It doesn't tell you if you have autism. It doesn't tell you if you have cerebral folate deficiency. It could be a tool, but your clinical provider would have to decide if that's helpful. I personally do not send that test. The real true gold standard to saying, do you have enough folic acid in your brain, is actually to do the spinal tap to get the fluid from the brain. Obviously, we're not going to be doing that on all our patients.
Yeah, tough to send it, right? Everyone for a spinal tap, not really practical or fair to our patients at this point in time. That's so helpful. Now, I think the inevitable question that comes up for me when we are hearing this type of information come from the highest levels of government is how can families tell, right? If a therapy that's being advertised online is legitimate or safe or still unproven, or like where do they go to figure that out? And maybe Gabby, I'll go to you.
I think it's very hard to remember that like most children don't do any one thing in isolation when they have a developmental disability, right? Or developmental delay. And so it can be really hard to tease apart what is what is the thing that's helping? Maybe everything is helping, because there's a lot of things happening at once. So Of course, we recommend talking to their providers if they have a developmental pediatrician or a psychiatrist or a neurologist or their general pediatrician to talk about what's first is always safe, right? We need to know that everyone wants to know that their patients and kids are safe. And then is it effective? And so if people are feeling unclear, I think I would point them to people on their team to help them make those decisions.
Yeah, definitely. And we have so many ways, right, nowadays to reach your provider. There's, a way to message on the portal, telehealth appointments. Like there's so many ways to be in touch, that really we're here to help, sort through all of these things. Speaking of something you just mentioned, Gabby, there's multiple things going on at once, right? Evelyn, we know that children with autism often have higher rates of things like ADHD, developmental delays, as Jen mentioned earlier, even later on, mental health challenges. How do you, as a general pediatrician, sort of look at the whole picture and decide on a plan that addresses the whole child?
Yeah, I think first and foremost, working together with the family to figure out, together as a team to figure out what is the most impairing or distressing, what we need to work on today because it's really distressing you the most. And then once we figure that out, being systematic about finding the best therapy, applying for the therapy, even though it's going to take a year maybe to get it, but really get on the wait list, start early. And then being systematic. So if, it's ADHD or hyperactive behavior, thinking about therapies that like structure reward stickers that will help both symptoms of ADHD as well as autism symptoms. So trying to sort of collaboratively think about what would be your best bang for your buck. And all of those disorders, have a multimodal approach. So there's therapy, there's also the educational system that we really need to get into early, make sure that you're getting your evaluations and reviewing them constantly, and making sure that we understand to the root of the behavior. So whether it's at school or through your physicians or providers, making sure you do behavioral assessments, understand what's causing it, and then what you can do either at the school or, at home or with a therapist to address the behaviors. And then, of course, the medication comes into. There are some conditions for which medication is first line, like ADHD. And so we would start those, earlier on if we think that the child does have ADHD too, whilst we're doing behavioral therapy. And just working together really as a team, assuring that, we address things systematically and then also have support for the family. So we reach out a lot to organizations and systems like OPWDD, which is the Office of People with Developmental Disabilities, so that families can have supports. Jen introduced me to Autism Speaks many years ago, and so I really do rely on Autism Speaks to provide support for families so that they can reach out either to support groups or, in school to the special education PTA so that they have people to reach out to while we're doing all of these therapies and treatments.
Yeah. It really is like a matter of like prioritizing, saying the whole child, as you just mentioned, Evelyn. And I think you're also getting at something that I wanted to ask you about, which is, what happens after the diagnosis, right? Because I think it can be extremely overwhelming. I think a lot of families tell us that they feel lost, right? There's like phone calls to make, emails to send, like papers to fill out, right? So what are the first steps, just to sort of go back for a second, the family should take after hearing that their child has autism?
Yeah, so this is actually where I sit down together on the computer and open up the Autism Speaks website, thanks to Jen's, she's smiling, education on the toolkit that's called the First 100-Day Toolkit. It's really excellent because it has step-by-step, the stages too that one goes through in terms of like awareness and acceptance. There's like 4 A's and there's calendars and there's contact lists of like really the information that you would need to move on to getting those therapies and the people you should reach out to early on so that you can have support. It's overwhelming overwhelming. And so I also do step back and say, like, I acknowledge the feeling of overwhelm and just say, we need to take time and, practice grace. And so just wanting to acknowledge that. And then just, one step at a time. It's iterative. So that's why I love primary care. We're going to talk about what the diagnosis is today, but we're not going to solve it all today. You'll come back in 2 weeks, 4 weeks, and we'll talk about it a little bit more. And referring to our lovely specialists so that they can help us. But those are the first steps.
Yeah. Gabby, and something we were talking about a little bit before we were officially on this evening is access to services in New York City specifically. What does it look like? I almost want to ask you, like, if you had to grade us, like if you had to give us a grade of how we're doing and how our kids are able to access services, what would you say?
It's so hard because I've lived in New York now for a long time, and so much of it would be a comparison, like what's happening other places, and I'm not even totally sure I know what's happening everywhere else. So I'm not sure I can give us a grade, but I can say that there's definitely room for improvement. So I could, talk for hours about services available in New York City and the surrounding areas. But there are services available for all children in New York City who have autism, but also who have any developmental delay. And so remember that children under 3 can receive services through early intervention. Early intervention can go into the home, it can go to daycare, it will go really wherever the child is, and it will provide services if a child has a delay or meets criteria for kind of one of their what we call automatic qualifiers. So like may qualify for services because they are at high risk for a developmental delay. And so early intervention will provide usually like speech, physical therapy, occupational therapy. It can also provide ABA when kids get older. Between 2 and 3, sometimes they do like a center-based program for kids who have high needs. Early intervention does do their own autism evaluations. So there are kids who have evaluations and get connected to services before ever having to see a specialist. This is so important because the wait lists to see specialists especially for autism are very long. And we know that early access to service is really one of the most important like predictors of outcomes. So we really want kids to get access to service early. And then remember, after 3, kids are going to get their services remember, these are federal laws. So it could not be New York City. It can be other parts of the state or other states as well. But after 3, kids are going to get access to their services through the school district. So that's more local. So that has to do with where you live. New York City is confusing because early intervention and the school district are all for New York City. But in other places, early intervention is run by the county, through the county Department of Health. And school services are run locally by like your local town or city board of education. So in New York City, we have a Department of Education that has 2 areas, right? The preschool group and then the 5 and up group. And so kids can have evaluations and receive services there, but that is less home-based and that is more school-based. And so those kids are likely in some kind of school program and getting some kind of services. Kids cannot be in a special education program and be in a regular program and get some kind of push-in services if special education isn't what is needed. So it really depends on kind of where you are and what is happening with the child and their needs. But that is where most people get services. And then to remember that insurance also, then like there's this other bucket, which is like insurance level services. And kids can get services through outpatient providers outside of the school district or early intervention if they desire. And so there's a whole other thing that sometimes happens. And like we were talking about feeding earlier, feeding is offered through early intervention, but really isn't offered through New York City DOE. So we often are asking families to try to get feeding covered as an outpatient, which is, as we all know, incredibly difficult to do because maybe not everything is found within the school system. So it really depends. And part of our job is to help families figure out how to navigate these like incredibly complex systems.
Yeah. And we're so fortunate to have support teams within, right, Columbia and New York Presbyterian that help us figure out what's happening locally to get families what they need. One of the questions that we had come in to the chat was, how do you get a diagnosis the quickest and get going the quickest? And it really is early intervention early on. And again, they can make that diagnosis before you see a specialist like Abby, like Jen, because the wait list is long, definitely. The other thing, I always sort of try to keep in mind, and I wonder if you all can weigh in on how this plays out, right? But socioeconomic and language barriers, how are those affecting families' abilities to get a diagnosis, get services, and how do we bridge that gap a little bit better? Jen, I'll go to you.
We need to do better. In the US, we have a program called the ADDM, where they're doing like monitoring. So you hear the numbers 1 in 39, 1 in 52. That comes from these larger networks of statistics from the CDC, the Centers for Disease Control, and they've been doing this since 2000. They are looking at race and ethnicity and language. We've definitely closed the gap on a lot, meaning we know that white children definitely are the earliest diagnosed. Females are getting more and more highly diagnosed at a younger age. Black children are near white children now, but Hispanic we know is lagging and they get a later diagnosis. So we are able to look at where the gaps are, where the delays are. Like I said earlier, autism is everywhere, not only in the US, across the world. So it's certainly something that I just ask like our trainees and our providers to continue to be aware of, that this is a gap that I need to know about. And so if I have a patient and I don't speak their primary language, I need to see if I can find their primary language provider who can do an appropriate evaluation, or just be aware of that and recognize that. And then for parents they can advocate and say, I'm concerned I can't find, I recently am trying to find a Portuguese speaking provider who can do the autism ADOS gold standard. And even our neuropsychologists say that using a translator is not ideal. It really isn't. So I think as long as we as a society recognize these are the gaps, we need to do better here. And as a parent advocating to saying, I'm not sure this is the appropriate representation of my child, then hopefully we'll get closer and closer to making those gaps smaller and smaller.
Yeah. Evelyn, what role do parents play? Because we do sort of say, like, yes, we want parents to advocate. I think sometimes I can feel a little bit abstract, right? In the mind of a parent, especially in the face of a new diagnosis. Like, what does that look like in reality?
Yeah, it's really hard and it can be intimidating because it's a confusing system. So where we might want to be proactive, like where do we even start? But I think using the school system, like Gabby said, and getting on that, SEPTA, the special education PTA, going to that group and just voicing your concerns. And even with the pediatrician or specialist, if you're waiting for those appointments, just continuing to, ask the questions, because sometimes I know there's a lot of reassurance that pediatricians and teachers in schools do, because they really do feel, that a child is doing well and they want to provide reassurance. But if you're uncomfortable, continue to ask those questions and push for it. There's also advocacy agencies and programs. The one in New York that I use often, not to use a specific one, there may be more, but is Include New York City. And we can Google, we can send these information, but they have advocates who can really help you make those phone calls to the school, write those letters where you're really wanting to ask for more services, better services. And even in your, pediatrician's office, there's social workers, we have community health workers, case managers, lots of folks who really are here to help. So just asking for that help, because it is there. It seems like it's limited, but the more we ask, the more we maybe find.
Yeah.
I'll just say, you asked Edith, like, what is our grade? Again, no grade, but I think that the thing that's so hard for families, right, is that there's really a wide difference in services that different families receive across the city. And that has a lot to do with different, like, individual districts and meetings that are happening for IEPs, but it's also about how well a family can advocate for services, right? And what we know is that families who are able to advocate or have someone come to help them advocate are more successful in getting the services that their children need, because it unfortunately can be hard. And so we want to really empower them to stand up and, tell them what we think they need so that they can
Mhm.
agree or disagree and kind of talk to the school about it.
And
Yeah.
I'll throw on there that Autism Speaks, again, I think there's definitely been controversy and questions about Autism Speaks as an organization over the years. That being said, they have phenomenal toolkits, very evidence-based treatment algorithms. They have a whole page on non-English resources that I put in the chat here. They do have toolkits on advocacy for parents. How do I learn about the individualized education plan, the IEP in school? How do I advocate in my community? Those are things that we continue to need to do better. And there's a lot of nonprofit organizations in New York City, as well as nationally, but New York for sure, to help families feel like they're advocating and getting the best care that they can get for their children at home, in school, in the community.
Yeah. No, definitely. This is all so helpful. I have one last question for you all, and then we can turn to a couple questions that have come in. And if you want anyone who's listening this evening, that is the benefit of joining in real time. If you want to ask any last minute questions, please send them into the Q&A. My last question is something I really worry about. Is the future of children with autism spectrum disorders, especially those who have a higher level of needs. What does that future look like? And are we, I think, prepared as a society to support those kids as they get older? And I'll go to all of you. Whoever wants to tackle it first.
So there was a term that was coined a few years ago. Somebody asked in the chat actually about, do we use the term Asperger's anymore? We do not, for a variety of reasons. But I think in general, we do in the current schema, we use an umbrella diagnosis because we turned away from having childhood disintegrative disorder, PDD-NOS, which many of our older patients had got when they were younger, autistic disorder, as well as Rett syndrome and Asperger's. We don't use those terms anymore. We use everything as an umbrella. And then in order to kind of further qualify level of need, because we recognize that every patient looks very different, they certainly don't fit into 3 levels, but we're giving them 3 levels. Level 1 means needs support. Level 2 means needs more support. Level 3 means needs significant support. I will emphasize to parents that those levels really are not helpful, especially when kids are young, right? We're talking older individuals. How much support will this person need in adulthood, right? Are they somebody, as you mentioned, who have some high support needs? There's a term that came up a couple of years ago as well called profound autism. These are individuals who have significant intellectual challenges in addition to the autism diagnosis. These are individuals who really need full-time support, full-time care for their life. And there's a big push to saying we need to embrace and include this group just as much as the individuals who are more on that level 1 who need different types of support. So I think just recognizing and making sure that we're advocating for all groups within that umbrella is so important.
Yeah, I think the future is bright actually, though, because there's so much more awareness now and so much more research. There's a question in the chat too about talking to older children about their diagnosis. I don't know about you guys, but I think they should. I think we should all talk about it. We should use the A word, right? And say autism. I didn't always used to want to say it in clinic because I wasn't sure. I didn't do an ADOS, so I wasn't sure they had autism. But now I'm like, they may have autism. And once the child is old enough to understand that, I think just accepting it will really help us as a society to move forward. So really just, yeah, be
The
open.
more you can use the right words, the more we're destigmatizing the words for across the spectrum, but also like it's important for kids to understand so they can advocate for themselves if able, right? So we want kids to understand their diagnoses as they go out in the world, if they're, as independent as they're going to be, so that they can advocate for their needs. And so not telling kids doesn't set them up for success in that way. I do think the future is bright, and there's obviously there's a lot of interest and resources being put into autism at this time, and that is wonderful. I think like on an individual patient basis, and when I'm seeing families, I think the concern is often for kids who are going to have more significant needs or kids who are going to have profound autism, just how are we supporting them? What resources are available for them out throughout the lifespan? and making sure that we are really maximizing the services that are available for them, I think can be hard. And I sometimes am worried that we can't give them as much as we would like.
Yeah. I share that worry, Gabby. And yes, as I think my own patient population as a primary care physician, right, like gets older, that is, a real concern, right? Like, can we give them everything that they need and that they would like, right? Thank you all so much. I think we answered all of the questions that came in through the chat in one way or another, either live or we typed it. I cannot thank you enough. I do want to do one last plug before we go this evening, because I know that a couple people hadn't joined when we talked about it at the beginning of the webinar, but we do have an amazing virtual conference coming up December 6th through the 7th. It is the 12th annual Pediatric Specialty Updates for the General Practitioner. I believe both Gabby and Jen will be speaking. Is that correct?
We are speaking at we have an autism one that I put in the chat that's in January.
You have spoken in the past, and the topics are incredible this year. We sort of change them up every year. The topics are amazing this year. The conference is incredibly competitively priced in a year that I know has been tough for many. And we will be sending you the link to register. And after you register, if you're out and about holiday shopping that weekend, the talks are available for 3 months after. So we do hope that you consider registering. And with that, thank you for spending your evening with us. Thank you for watching us on YouTube if that's where you caught us later. And thank you to our amazing, amazing panelists for making time on a busy evening to give us all their wisdom and knowledge. Thank you all.